the generative AI is our next journey where you're asking it to summarize the notes. And clearly a massive benefit if you're coming on to intensive care to start your new block, you've got patients who are very complex in there, clearly you'll have a handover process. But if I can just say, summarize the chart for the last 72 hours, give me the severity of points on fluid balance or whatever it might be, that's going to be a huge benefit.
Hello and welcome to The Connection, where RLDatix's Chief Customer Officer Liz Jones and Medical Director Darren Kilroy are joined by leaders and colleagues from within the healthcare industry. In The Connection, we explore how people and technology in healthcare can come together to create great experiences and support patient safety. We hope you enjoy listening.
From a patient safety perspective, I'm wondering how closely, as you start to, I know you're at the start of your journey around Ambient, but it really changes the work that the patient safety team are going to do. And as you know, we're the RLDatix system as well. So I'm just wondering what your reflections are on that and how closely the patient safety teams work with you on some of these new innovations that are literally changing how care is delivered.
Yeah, I think particularly, again, and that's where Clinical Informatics plays a big role in that sort of patient safety piece. Because yes, we work very closely with our patient safety teams, and I think for particularly nursing, if we get Ambient right, we can again transform nursing care. Because even when I speak to my CNIO, trying to lighten the documentation burden on nurses, because obviously with an opportunity with digital, you can document everything, but what you clearly need to do if you're trying to recycle care, and I think Ambient doing well in that. So you got, we're already seeing demos where flow sheets are being automatically done by the Ambient technology. But from a patient safety perspective, that releasing hands-on, because you're literally just hands-on with the patient on top it and just capturing the information in the background. Clearly, don't want to validate it, but I think really transformation in our nursing documentation space. Yeah.
Slightly different question, briefly, and I know we'll come back to data in a minute. But what if we bumped into you tomorrow in your role? What tech are you using yourself, like day to day? What's the
So I am using Ambient. So that example of that patient is a real one. So I'll be in the ED tomorrow, and I'll be using the Ambient technology with the patients there and then. So it's great. The ECGs, going back to my first example now, are purely electronic, end to end. I can see it in system. I can report it in system. Everyone else can see the report. Everyone else can see the ECG. So just a couple of examples there. Yeah. Just quickly, that one, Heather, when you're using the Ambient in the department tomorrow, how do you get the patients aware of the fact you're using it? What sort of script do you use when you come across a patient for the first? Yeah, so it's a verbal consent process explaining that the data is exported or remains within our record, and it's interpreted, and then it's only an interpretation of the data which is used to utilize. I always offer them the opportunity to look at it to see what the output is themselves. And a couple of times, because again, the importance of we are on a journey with this, and hallucinations are real. Like, oh no, you didn't actually say that, did you? It was their interpretation of the AI's interpretation of it, and that's why implementation of it is so more to understand that, especially the implications of a hallucination from the Ambient, which isn't recognized. And that's why, going back to my piece of, you've got to read this, because we haven't been, the generative AI is our next journey, where you're asking it to summarize the notes, and clearly a massive benefit if you're coming on to intensive care to start your new block, you've got patients who are very complex in there, clearly you'll have a handover process. But if I can just say, summarize the chart for the last 72 hours, give me the severity of points on fluid balance or whatever it might be, that's going to be a huge benefit. And and also what we've started to explore is what that looks like because we still communicate by letters and discharge summaries, bonkers, isn't it? In this digital world. Whereas, ideally the GP would say, can you just summarize what the last hospital stay was, as opposed to, you've sent me a discharge summary with 10 pages and listed every medicine they've had, and et cetera, which is, we think, oh, that's a good thing. We look at this in and well, I'm not going to read that.
So is that, someone may choose to edit this bit out, all right? So if it stays in, this will be a pleasure for everyone to listen to. So, when you look at those notes, quite often, and I think to people on clinical, it's always really curious where there's a very pleasant lady or a lovely engaged family. Those comments, I think they're wonderful, right? And I always think there must be a reason that's trained into what you do.
I remember those days from like the early sort of sitting in with a consultant position. Work? Many thanks for seeing this delightful gentleman who presents with X, Y, Z. Yeah,
you want to see an end to that?
No, not at all. My first question, I guess, is that presumably is there for a reason, or is it just tradition of the profession? Right, okay.
It has nothing to do.
So we're losing, because that's going to be very hard to do in this new world.
What's really interesting, some of the reflections on the AI-generated responses. So already you can have an AI-generated, so a patient will ask a question and you get an AI-generated response. And if you hear some of the feedback, the patient say, oh yeah, this is much nicer, it's much more friendly, it must be human. And actually, no, the AI is the friendly one saying, I hope you had a great holiday, and here are your test results, don't worry. Whereas a clinician, test normal,
Got it.
No,
okay. So we're
going to say, I hope you had a great holiday.
This is amazing. So what you're saying there is actually AI is bringing more humanity. Yeah. So that's fantastic.
Or perceived humanity.
Perceived humanity. That's right. Hannah Fry actually did this great thing a few weeks ago where she said you're going to get better results from ChatGPT if you're basically seriously polite with it. And I tried it. Okay. I did. I'm sycophantic now. I talk to it. I'm like, we're now in a relationship. Yeah.
Back in those days when the lads would say, "May actually this delightful gentleman." No, we'd stay to see this annoying person. It's always delightful. And that my interpretation of it was he was sort of psychological trickery and tradition, whereby you were sort of inferring that this patient was a bit more worthy of attention. Though perhaps you didn't put the qualifier in to say many thanks for seeing this person. The delightful bits was to, oh my God, you're with Ava. You're extra test. But I'm just conscious of time. Once we mentioned the 10-year plan, and it's been fascinating talking around AI. You touched a few moments ago on sort of operational issues around getting through waiting lists and things. And I just wonder what your reflections are on how you're using your expertise and your team's expertise to try and grapple with operational issues. We wouldn't have a massive focus on waiting lists in the 10-year, but how do you bring that into the operational world? Yeah, really, really good point. And again, as soon as you go digital, you expose your data in like no other manner. And so that's the key thing is as hospitals go digital, there's often a dip in performance. It's weird, but it's just because you've got the visibility. And so I think that's a word of warning is, that you'll see that. Again, going back to my earlier point about making sure all your staff are on the journey, because making sure from a waiting list perspective that your data accuracy and data validation is key. And we're spending a lot of time on that at the moment in improving performance. Is about the accuracy of the data and the data validation. So I think that will be a crucial point. Going back to there certainly will be opportunities to streamline, because once you've got it in the digital space, you then can do this sort of fancy stuff. Because again, a lot of waiting list validation, you could be running a bot through. Again, how can you prioritize my waiting list based on X, Y, and Z? And so, if we look at our diabetics, if we've got all the system all the data in the system of their latest kidney results, they stage B1AC, other comorbidities, you could streamline and risk stratify that waiting list in no time at all. And then I think working then with the operational staff about those new models of care for chronic disease. And I think that's going to be really exciting how that fits in with the new plan and use of digital, of transforming how if you've got a chronic ailment, don't expect you need to go to hospital every year, sure. But you'll only be going to go to hospital if you need an examination or a procedure or a diagnostic. Everything else will be done in your own home, working very closely with primary care colleagues on how that's delivered and that risk stratification. So I think that'll be a really exciting journey, but you're particularly working with the operational teams about how you transform your waiting list to X, Y, and Z. And again, if it's looking at how you best use advice and guidance, and again, some of it is breaking down barriers, because we're still putting advice and guidance in one camp, referral in the other camp. Actually, it's all about communication and what's the best for the patient. And if you could do that at scale, then again, you're talking about rapidly huge improvements.
I'm always struck by whenever, and understandably, whenever people look at I've got a waiting list problem, the reflex action is, just throw more doctors and nurses at it and do more operations. But of course, as you say, one of the key aspects of doing it is to tidy up the waiting list, validate the queue, and make sure that what's in it is legitimately there. Yeah, and unless and until you've done that, there's no point for weekend lists out, because you're just wasting time and cash.
Exactly, and I think even more so with that is you're probably best spending more money on validating than paying expensive staff to come and work when they may not need it. I think the other huge element to this, which we haven't touched on as yet, is the training of the staff. Because again, and that comes back to the data validation, is we could completely change our RTC performance with actually it's not, we're not taught about RTT in medical school. No one knows what it is, and it's not intuitive, and so you have to be trained to know how you take people from the clock stop to bone stop, and again, making that very easy and ideally happen in the background. So, as a clinician, you're just deciding what happens to a patient next to the clock stop RTT, but is it all that data validation happens in the background? So that's where we want to get to using the digital tools.
And just to stop our readers Googling this, Henry, RTT, referral to treatment. Yes, it's when the clock starts and the clock stops. Yeah, you're absolutely right. There's no training on that at medical school. Again, your life is driven by it. Let's see.
You mentioned there in terms of how much care is likely to be delivered outside of a hospital setting, and that's been talked about now for 20 years plus as an aim. But now with the triple shift, and one of those shifts being the technology, if somebody's listening to this and they're a cynic because they've been around a long time and they're like, I've talked about this forever, nothing's really going to change. If you were predicting the next 10 years, what's your view in terms of that shift to community delivery of so much more care, and what part do you think the tech plays in that?
So, who I am, I'm going to say I think we can make a significant change, and the digital is going to play a huge role in this. But clearly we have to be honest. We haven't seen a massive change in resource and how that's going to happen. And so what we need to do is empower the patients to be able to care for themselves and be far more engaged in that journey themselves as part of that left shift, because some people do want to come to hospital and see the specialist. But I think, again, that's an historic sort of urban myth. Is at the end of the day, you don't really want to, if you don't have to, be quite happy to stay in your own home and be advised, as long as the advice is correct, via a digital device. So you're doing well. And also, again, it's about using the tech. I think the explosion on the use of wearables, but then using the data from them, if you've got a chronic disease, to say, actually predicting your exacerbation before it even happens. Because actually, we can see from your biomarkers from your wearable device, you're not so well. So we probably need to do something about that. We need to change medicine X, Y, or Z before you're fully exacerbated and in the ED with being much worse. So I'm relatively confident we can make a significant change around that. But again, it needs to be co-designed, well adapted, clearly led. Easy things to say, but very difficult to practice.
And that co-design. So obviously the resources bit, I think everyone agrees with that. But that co-design bit on the back of what we heard last week, which is the in terms of the public attitude survey and people's view in terms of, I know this is really hard conversation, especially for people like you that have worked and still work so hard delivering care, but there is something in terms of the contract with the public, and maybe this is an opportunity to do something positive there rather than narrate what has been, a number of difficult years. I don't know what your view is on that, but that will be really interesting.
We're in a really transitional phase in all this, I think. There's a generational, we're at one bit of this generation ourselves, us in from self, our age. We're sort of catching up to this in the way the human brain works. We're catching up to this late in our brain journey. A lot of people are really young and vital and vibrant. It had been staging it since birth, and it's much more real. Even the social media kids and the way that they live their lives. So I think some of the attitude survey stuff reflects probably where people are at generation.
Expectations.
Yes.
Yeah.
That's my view on it.
Yeah. But it's pretty tough, I guess, for you in practice to have that narrated out. But there is an opportunity, I think, with the tech to change people's interface and experience.
Yeah, for sure.
So can I ask a question about data? Because you talked about how important it's going to be in terms of, everything, but particularly around population health, and you use the example of sort of population level data for the waiting lists. What role, there's been a lot of noise around the FDP for a couple of years, but over the last few weeks in particular, as some of the data gurus in the NHS have sort of argued where should the data live, where is the data most useful. Just interested in your view in terms of the role the FDP's got versus sovereign organisations and how you see that playing out.
Yeah, I think really fascinating and uncertain how it's going to play out. But I think, again, it's the attitude of the data, isn't it? Again, it's become far too politicised, unfortunately. At the end of the day, we need to, stress this is anonymised data. But again, back to our kind of restraint and resources question, to enable us the staff to do some of this kind of inspirational change and all this stuff, you have to have the data. And at the end of the day, how we use that data is very important. But as an individual, as a patient, it's getting some of that politicization and almost sort of inaccuracy sometimes around what's going to happen to it and what it's going to be used for. And it's not very rarely is it ever going to negatively impact what's going to happen to you. And actually it's going to make huge change to the NHS if you use it properly. And so I think very much some of that is that data controller argument is going to be a big one. And we need to land that right at the end of the day. And some of this, is an ideas we've had locally about enabling patients again to be data champions themselves. I say, and we want to get you involved. Actually, your data is really important to us, but you can work with us. And do you want to join it to be one of our sort of data champions? And so we're starting to expand that. But again, to your FTP argument, clearly, if you can utilize our national data set, absolutely, the opportunities are massive. And kind of nationally or regionally, yes, definitely there's opportunities. We locally and are utilizing FTP for like utilization, and there's definitely opportunities, especially if you haven't got a unified health record. Even more so, if you've got best of breed and things sitting across, then I think you've got even more opportunity with products like the FTP.
Yeah, and I think externally, some of that is telling the stories about how difficult it is to get a national picture, actually. I think possibly, and particularly if we're talking about public and citizens, because they think the NHS is one thing often, it's really hard for them to understand how difficult that is. I know during COVID, we were able to put the availability data all into the FDP. So from the Allocate systems that fed it in for the first ever national view of people's availability for the purpose of vaccinations. And I think most people thought that was just stuff that people would have. But it was incredible. It was only able to happen because of that intercode between an infrastructure products like the Allocate one and the FTP as an enabler. So I'm sure there's many other examples.
And again, I think back to our patient safety discussion, that staff acuity data, the availability data, again, we should be in a world where that's happening automatically because, it's sitting nicely there, beautifully mapped out how many patients, how many nurses are a shift, et cetera. Integrate that. And again, you've got the real opportunities there. But again, some of it is, again, everyone talking nicely to each other from a data perspective and breaking down some of those barriers about how that integration has to happen. And we're still thinking about repositories where you bring data in and you think, actually, if you speak to some of the big providers, go, well, why can't we just talk to each other? Yeah. But that's where we kind of need to get to really enable some of this.
Yeah, I've got one last question, a summarised type question. So where do you think innovation comes from? Does it come from the tech providers? Does it come from service users? Does it come from the problems that you've got from clinicians?
All of the above.
I should have asked that question, just where does tech come from?
But I think, and it has to be, again, successful innovation has, again, an obvious statement, but it has to be a multidisciplinary team effort. It's easy to say co-design, but for it to be successful, you need the tech guys. If we look at some of our successful go lives, we have to have everyone aligned, and that's from the patient, from the staff, to the clinical informatics, to the tech guys, to everything, and they all need to align for that for it to be successful.
Yeah, absolutely. No, Henry, it's been so great to talk to you today. They're fascinating. We could talk forever, probably talk again sometime. It's very grateful for your time today. But for that, we'll leave it. Hope you've enjoyed that. Yes, it's been great.
Thank you, sir.
Thank you very much. Thanks, Henry. Cheers. Take care.
Thank you for joining us on today's episode of The Connection. We hope this episode has provided you with valuable insights on the role that both technology and people play within the healthcare landscape. For more information and resources, visit RLDatix.com. Don't forget to subscribe to The Connection on Apple Podcasts, Spotify, or any other podcast platform you use. Join us next time as we continue to explore how healthcare is impacted by connecting people and technology. On behalf of the RLDatix team, thanks for listening.